Big news! Multiple generic entries for Farxiga, dapagliflozin, are expected this April before others in the class. Another reason to prescribe Farxiga today. View efficacy and safety information at farxiga-hcp.com.
Farxiga.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. I'm Shazli Khan, co-chair of the CardioNerds Advanced Therapy Series. Welcome to episode 4, where we discuss post-transplant management. So far, we've covered advanced therapies evaluation, pre-transplant, and perioperative management. Be sure to check out those episodes if you have not already. Today, we'll be focusing on post-transplant management of immunosuppression, rejection, long-term complications like cardiac allograft vasculopathy, and the overall prognosis for heart transplant patients. I'm joined by the chair of the Advanced Therapy Series, Jenna Skowronski, who also serves as chair of CardioNerds Heart Failure Council and will be joining faculty at University of North Carolina. Welcome, Jenna.
Thanks, Shazli. I'm excited for a great episode. For today's episode, we're joined by Shiva Patlolla, who started out with CardioNerds during his general cardiology fellowship as a FIT trialist. He's now an advanced heart failure and transplant cardiologist at Baylor University Medical Center in Dallas, Texas.
Thanks, Jenna. I'm really excited for our discussion because we're joined by two international leaders in the field of transplantation. We have Dr. MaryJane Farr, who is the section head for heart failure, MCS, and transplant at UT Southwestern here in Dallas. She previously spent her academic and professional career at Columbia University in New York, where she also led the transplant program prior to arriving at UT Southwestern in 2021. We're grateful to have you here in Dallas and with us today for this episode.
Great to be here. Nice to see all you guys.
We are also joined by Dr. Shelley Hall, who is also from the Northeast but made her way down to Texas for college. She stayed for medical school, residency, and fellowship at UT Southwestern, after which she began her clinical practice at Baylor University Medical Center, where she's been the chair of transplant cardiology, MCS, and heart failure, and my current boss. So we're excited to have you with us as well.
Thanks for inviting me. I'm looking forward to the discussion.
Welcome, Dr. Farr and Dr. Hall. We have so much to cover, so let's dive right in with the case. We have Mr. FK. He's a 64-year-old male with a past medical history significant for non-ischemic cardiomyopathy and HFrEF. His ejection fraction is 10 to 15%, and he has a confirmed Titin mutation. He's now post-op day 0 from his heart transplant. He was not sensitized going into transplant with PR8 class 1 and 2 at 0%, so he received no induction agents aside from the typical steroid regimen intraoperatively and post-op. On rounds, the CVICU team is asking you what his immunosuppression regimen will be. By way of background, one of the cornerstones of post-transplant care is immunosuppression. The field of transplantation took a massive leap forward in the 1980s with the introduction of cyclosporin, leading to significant reduction in rates of acute rejection. Since then, we've added more options to our toolbox, including calcineurin inhibitors like tacrolimus, antimetabolites like mycophenolate, that have continued to improve rates of rejection. In the current era, most transplant physicians are now looking to minimize the burden of adverse events related to chronic immunosuppression, and we have a lot of work to do in drug development for new immunosuppressive agents. Jane, can you talk us through the basics of immunosuppression in the early post-transplant period and how we go about weaning these medications over time?
Yeah, sure. I'd be happy to. Patients are on the spectrum of folks who you are expecting for them to have a rejection and other folks who you are expecting to them never rejecting whatsoever. And that typically falls along the lines of age or sex or prior sensitization. But the thing that all transplant centers do is just start with protocols. Patients deviate from protocols soon enough, and that's perfectly fine. And we'll talk more about that later. But we all have standard protocols that we adhere to for intra-op and then post-operative time. And that typically includes either induction therapy or not, depending on how sensitized or risk of rejection there is in the particular patient. And then we have core therapies, steroids, calcineurin inhibition, and then antimetabolite therapy. So those are our standard therapies that we try to get these therapies on board as quickly as possible. And we do this in a very standardized fashion. And there are some nuances, renal insufficiency, infection risk, and so forth. It's really only when you walk back from transplant, make sure graft function is good, there's no rejection. When you start to nuance a little bit, because patients, like I said, are different.
Yeah, I think the only thing you really can say is that transplant programs agree on the basic principles that Jane just covered, but how we apply those, when we apply those, and in what circumstances vary tremendously.
Mr. FK is now 6 months post-transplant and has been hospitalized several times with multi-drug resistant urinary tract infections due to a urinary stricture. He had an early 2R rejection due to a slow rise in his tacrolimus levels, but has had no rejection since, with excellent biventricular graft function, and steroids were able to be weaned off. He is currently maintained on tacrolimus at a level of 8 to 10 and MMF at 1 gram oral twice a day. Dr. Hall, how would you handle a patient who is doing well in terms of graft function, but struggling with these recurrent infections? How would you adjust their immunosuppressive regimen? And besides infections, what are other common issues encountered post-transplant that would make you consider a reduction in patients' immunosuppression regimen?
Yeah, I think what we know about patients is that as you age, your immune system gets weaker. And so your risk of rejection tends to go down and your risk of infections and malignancies go up. Now, there's no magic number, there's not that certain age, and there's no universal protocol to how you approach it. The 2 drugs that he's on is relatively standard across the transplant community, but the dosing can vary tremendously. And that's just starting with the standard protocol. Yeah, for my program, we use half that dose of mycophenolate, and our target for Prograft is lower than that as we get closer to 1 year because of his age. Other programs would be approaching everybody with the same dosing and only adjust if they have a complication, letting the patient's physiology drive the change in dosing. And so recurrent infections is a common thing, especially as you get older. And we tend to downplay some of these routine things. You mentioned a urinary stricture. Well, in a non-immunosuppressed patient, that may not be a big deal. But in an immunosuppressed patient, it becomes a very big deal in recurrent infections. And as you mentioned, then developing multi-drug resistance, because he keeps getting treated and develops these resistances, can ultimately be a life-threatening condition. So we don't necessarily need a particular test to tell us that this man is over immunosuppressed. He's showing us that with the recurrent infections. And we've got to make an adjustment if we can. So for this particular gentleman, I would tend to go down on the mycophenolate first, but there's absolutely nothing wrong with also lowering the Prograft level, the FK level, because he's probably developing some renal insufficiency with recurrent UTIs and infections as well. So I don't think there's a right or wrong answer. I think if you poll the community, you probably get an even split. I don't know, Jane, what do you think?
Yes. So it raises a couple of things. Years ago, 2 centers did something called the Tic Tac trial, and that was really just tacrolimus only. It was a pretty bold thing to do, but the data was okay. There was some early rejection. There was probably more later, renal insufficiency, but there are individuals that can be on single drug therapy only. It's not something I would do. I would do exactly what Shelley's doing, and that is just give this person 2 drugs at much lower doses. I guess maybe the third thing I would do is check a gamma globulin level and see maybe for whatever reason this person needs repletion with IVIG to facilitate clearance of infection. Infectious disease doctors don't really love that idea, but we do it anyway.
That is something during my transplant year that I was so perplexed by. We would just randomly check a level, decide if we wanted to give some IVIG. And it was a new integration into my care model. I guess thinking about less acute and more like long-term indications for backing off on immunosuppression, particularly as we get further out. You mentioned nephrotoxicity, but what are other side effects or complications you might expect to see from immunosuppression that would make you want to reduce or preventatively, I should say?
I think each drug has their long list of potential side effects, and we do the teaching of the patients beforehand, letting them know they're not going to remember any of that. They're just focused on getting a heart transplant. And then you give them their magic binder afterwards with all this information. So the calcineurin inhibitors, cyclosporin and tacrolimus, they're notorious for tremors at high doses and nephrotoxicity. With mycophenolate, they're notorious for GI distress, low white counts, and other marrow suppression, and an increase in viral infections, particularly for that. And then steroids are just steroids. They, are associated with everything. Most programs, I think we're up to, 80% plus are probably off prednisone by, this one is at 6 months, but certainly by 1 year. And usually they're on a 2-drug regimen. Obviously, more long-term is going to be the dreaded malignancies. Your immune system is responsible for surveying and getting rid of those pre-malignant cells, and it's now being suppressed. So malignancies can grow faster, and that's everybody's fear. But there's also hypertension, diabetes, all of the things that they may have had already and now are getting exacerbated by these drugs. And you have to look at the individual patient to figure out, where do I adjust? How far do I adjust? How much risk do I take by adjusting to try and mitigate those potential side effects?
All right. Thank you both so much. I think your discussion really showed the importance about how tailoring immunosuppression to each patient's individual needs is really key. So now that we've discussed some complications of immunosuppression, let's shift our focus to rejection. We have another patient, Miss Peripartum, who is a G3, P3, 36-year-old female with a past medical history of non-ischemic cardiomyopathy secondary to peripartum cardiomyopathy, who's now status post-heart transplant 10 months ago. Prior to transplant, her PRAs were Class 1, 55% with 30% C1q positive, and Class 2, 75%, 65% C1q positive. She's now coming to clinic due to volume overload and an elevated BNP, reporting that she's had some difficulty remembering to take her immunosuppressive medications as she's been caring for her children at home. She's admitted to the hospital and sent for endomyocardial biopsy, with high concern for rejection, as her tacrolimus level is 2 with the goal of 8 to 10. So I suspect many of our listeners have heard of rejection, but perhaps we could give them an overview of the types of rejection and the different reasons that rejection can happen.
Unfortunately, the case that you provide is pretty typical. It is very hard for young people to manage all the things that they need to manage, and they are at high risk for rejection, especially those who go into transplant sensitized. We know a lot about HLA antibodies, and you sort of raise these questions. But even when you have a negative cross-match, patients can have shared epitopes. And so you find rejection, even though it doesn't seem like you would have rejection. But really, your case is focused on someone who's not been able to take their immunosuppression in a regular way. So what is rejection? And Shelly and I have talked about this a little bit in another scenario, but what is actually rejection? It's because we keep coming up with different definitions based on the assay that we use to define rejection. But really, the most important thing, the way I think about it and the way I teach it, is there's either symptomatic graft dysfunction, asymptomatic graft dysfunction, or no graft dysfunction. That's the first place to start. That's going to tell you whether you need to put someone in the hospital and then how intense the therapy has to be. So I think that's the first thing that we need to figure out. The next thing is, how do you assess for rejection? You're assessing for allograft injury. You can do that with a blood test, and we'll talk about that in a little bit, or you can do it with a biopsy. What we're trying to classify the rejection is this a primarily T-cell mediated rejection, such that you can use steroids primarily, or even thymoglobulin to sort of suppress T-cell activity? Or is this going to be a mixed T and B cell action? And is this, if you've got B cells there, are we talking about antibody mediated rejection? So the spectrum of those things, or how we use our different modalities, our tests to decide that. But the most important thing is whether there's allograft dysfunction.
Yeah, I think that we are evolving the ways that we are defining rejection or undefining it and teaching how to survey, because typically it's been divided into 2 types of acute rejection, cellular or antibody, and relatively simplistic, and it's hung around for a long time. And they have grading systems of severity based on biopsy. purely by biopsy predominantly are these grading systems. And as new technologies are evolving, we're questioning what is the real gold standard anymore, and are our definitions antiquated and outdated? And that's challenging because the past 30 plus years have been based on the biopsy and this definition. So as mentioned, T or B cell cellular rejection, which is often easily treated and rarely fatal and mostly asymptomatic, unless, as Jane said, you have graft dysfunction. And then that's a whole new ball game. And I think that the way she divided that is the more appropriate way to look at. It's not just a pathological diagnosis. It's not just a blood cell diagnosis. It's what's happening to the graft that really is going to, I think, define the future of our therapies and how we approach it. Because for decades, we've been over treating these patients based upon asymptomatic biopsies, in my personal opinion. And I think that that's led to all of the things we discussed about earlier about immunosuppression and toxicities related, because we were petrified of rejection. And we just said, okay, all those side effects are what you deal with to prevent rejection. And really kind of overcorrected out of a fear of we don't want them to reject. And I think that pendulum is slowly moving as we've got advancing technologies to help figure that out.
I have two follow-up questions for you. I think the first is, if you all wouldn't mind just kind of talking about, when you think of people that are higher risk for rejection, who might those patients be? And then second, I mean, as you mentioned, we talk a lot about rejection. We focus a lot on rejection, but also I'd love to hear a little bit of your thoughts about routine surveillance once we're not as worried about rejection and we're just kind of checking up on our patients. How often should that happen? And what are the methodologies that might be shifting right now in the transplant community about how we do that?
I'll take high risk features for patients who are likely to reject. You outlined for some of the sort of social features that people can't do what is necessary. And that is really, really important because it is really hard to take these medications and do this, routinely twice a day, if not 3 times a day for the rest of their lives. So it is really very hard for patients to do that. But what are the risks, some of the high risk features? I think, Shelley mentioned age. Younger people will reject in a way that older folks won't. That's the first thing. Sensitized patients will reject in a way that unsensitized patients won't. Even if you had a negative cross match, there's memory, there are epitopes, there's details above and beyond the things that we looked at classically. There are some additional details. High risk epitope mismatch. It's a little bit more of a detailed immunologic signature of patients that they're much more likely to reject than you would expect another person. So all of those things go into sort of sizing up a patient. If I've got a patient who was sensitized, but sort of had a very standard kind of routine transplant, but they're showing a little high risk epitope stuff, I might keep them on prednisone 5 and then keep them on a 3-drug regimen at lower doses. I might tell them up front, we're going to do this for a while. And as you grow older, we may move things down, but sort of do something slightly different for them. And that, of course, impacts on if you're going to be a little bit more intensive about your therapy and let them know, you might then adjust your surveillance as well.
Yeah. That pure routine surveillance. It's as routine as one transplant program. The transplant community agrees on concepts, but how we apply those concepts are so variable. And it's confusing for patients, especially if they move and they go to a new program and all of a sudden the routine is totally different. And that petrifies them. Whenever we have patients move in to Dallas and do what they start following with us, they're petrified because we pound in them to be super careful and super conscientious about taking your medicines. I don't know about you, how many times I've failed to complete a course of antibiotics, and we're having them do multiple drugs multiple times a day for life. So surveillance, talk about the concepts first. Routine surveillance is regular testing of an asymptomatic patient, and how that is varies from program to program. It can be from a biopsy every visit. In the old days, it wasn't uncommon for a patient to have 30 plus biopsies in their first year. or it can be blood tests. There are new types of blood tests that can detect injury of the graft called cell-free DNA, donor-derived cell-free DNA. And we can get into the more of those details if you want. And then there's indirect testing. There's measuring of antibodies. Presence of antibodies doesn't mean they're doing anything to the graft, but if they're rising, you get worried. There's echocardiogram looking at the function of the graft. Those are some of the routine options for surveying for rejection. The frequency with which is variable from program to program, but each program typically has a protocol in place of how they're going to do that surveillance. And I always preach that you can't assess outcomes if you don't have protocols. If you're not approaching patients in some kind of standardized fashion, when you're looking at your outcomes and trying to interpret something, how do you do that? And so most transplant programs will have some type of protocol in place for surveillance. It's most intense in the first 6 months because you've just put this foreign tissue into somebody and their immune system, it's like dropping into a beehive, right? That immune system is going to be very riled up. And so we're swatting it down with all these drugs. Then things settle in place. They kind of get comfortable with each other. You're slowly backing off on the immunosuppression and assessing where is that comfort level for the body's immune system. And then the second 6 months is typically a little less frequent surveillance. And then that 1 year, that first year is really the intense surveillance time. If they're going to have acute rejections, that's going to be the most common time. Very rare after the first year, unless they've had some major change, interruption in their medicines. That can be from not taking them to being prescribed a new drug that they didn't know interacted with those immune medicines, and now their levels drop too low. And so it gets much less intense after that first year.
That's really great. It sounds like you touched on different institutions having a little bit of a different approach to this. Based on both of your professional experiences, do you feel that we're ready to manage patients with non-invasive testing alone?
So I came from Columbia. We are a very biopsy heavy protocol, even though Columbia was one of the sort of early founders of the gene expression profiling, which is one of the sort of the first and only FDA approved tests to assess rejection. There are limitations to that. And cell-free DNA has been, of course, an absolute breakthrough in many areas of medicine. When I came down to UT Southwestern, it was a very biopsy heavy institution. I cut back on that and we brought cell-free DNA a little bit more, but we have actually, we continue to do more biopsies probably than many programs, certainly many more than Shelley's program, Baylor, just honestly down the street. There are a few important limitations that are not just about individual patients, and that is clinical trial data. And while this, we're in the middle of an RCT comparing head-to-head biopsy versus cell-free DNA, and I think it's a really important trial to finish. And the reason that is that you really need FDA labeling of biomarkers for rejection. This is really, really important. And so we want to move into the direction of being able to use biomarkers as much as we possibly can. We need to be absolutely sure that the FDA approves them so that patients can get them paid for. We don't want to be in a situation 3 years from now where suddenly patients are used to a certain way in which we survey them and then it gets pulled from them. And then we're back with biopsies. So there's sort of a reason to sort of stay in biopsies to be absolutely sure. So number one, from programmatically, I had to make a gradual change in my program, but also to finish a trial that I think is going to have implications, but implications on the side of moving towards non-invasive.
Yeah. So as Jane mentioned, our program is probably on the far end of the bell curve, and it really is a bell curve of the number of biopsies done in the first year per transplant program. And we're on the very far end where we only do one. And we adopted biopsy minimization way back in the first test, as Jane mentioned, gene expression profiling. And we weaned like half of the biopsies off over time utilizing that technology. And it was a slow process where we did them simultaneously for a year and a half, compared the results and found we weren't missing anything. And so then we did every other. And it was definitely a slow process. Cell-free DNA, I think, is being adopted faster by transplant One, because we're familiar with that type of biomarker, an injury biomarker. We have troponin, we have BNP. So we're used to that already. It's something we can get our teeth into. And as Jane mentioned earlier, graft dysfunction or no graft dysfunction is a real key differentiator in how we treat rejection. And cellular injury before graft dysfunction is theoretically precursor to injury if left unabated, whatever's injuring the graft. I think the challenge, I totally agree with, we want FDA approval, we want trials, we want insurance coverage. The problem is especially in the heart community, a lot of our treatments don't have FDA approval. They were studied in the kidneys, and we're using kidney drugs, theoretically, in heart situations because there'll never be a heart trial in that space. And as mentioned, I've mentioned the bell curve of biopsies. That's just one aspect of transplant management that is variable from program to program, which is why I think in the heart space, we've been very, very slow to advance medicine because we can't get all together and have, 20 sites doing things the same in a trial to answer a question. And so trials to involve a lot of heart programs have to have enough flexibility to allow the variability, but enough constant to have a logical conclusion at the end of it. So I think we're really challenged in the heart space for that FDA approval. I totally support it. That trial, I think, is crucial to getting finished. We were already so far past biopsies, I couldn't go back to my patients and say, you get to be part of a trial and get 6 extra biopsies. That's not something a patient's going to sign up for, but we need it because that will move the needle forward. And every patient, we're way behind other fields that have been using cell-free DNA for decades. I still remember my amniocentesis and that 24 hours afterwards, waiting for the results and making sure I didn't miscarry from the procedure. And now it's all cell-free DNA. Same thing in oncology. They don't need as much imaging or tissue anymore because they have cell-free DNA to survey for those things. So we're behind those fields with non-invasive surveillance technology. And cell-free DNA is just, I think, the tip of the iceberg of where we'll go. But we don't have robust trials, as Jane mentioned, to kind of push us to the next level yet.
I think one additional thing, very well put, Shelley, is that we also have to gain a little bit of comfort with a positive cell-free DNA. We have to, talk to patients that it's not, a cell-free DNA is not a positive or a negative. It is, of course, technically. That's how these tests have been designed. But patients who have a little bit of vasculopathy, and I know we'll get into that in a moment, or a little bit of smoldering injury that you can sort of manage with a slight augmentation of immunosuppression, this should not create a panic state for patients. And so we also have to change our own thinking, not just the physicians and the nurses and the nurse practitioners, but also to train the patients to say, you are on a spectrum of survival. And we are in the business of trying to, even though protocols are critically important, and especially early on, there's an absolute art to this. And you need to include the patient in on the art about where they are on this spectrum. That can change at any, they get an infection you adjust this way. They have a malignancy, you're sort of pulling back this way because you're trying to look at the whole patient and say, I really would like to see you live 30 years after transplant. That's where we're going.
Yeah, the transplant medicine is not binary. It's not a light switch. Patient is either 1 or 0. They're a compilation of ones and zeros and decimal points in between. And how many, points can you count pi out to? That's what transplant medicine is. And it's why I love it, but it's also what makes it challenging and I think slow to progress.
Yes, absolutely. I think context for any test is important in transplant patients because, as we've discussed, there are so many patient characteristics that can influence your decisions. It's important not to take a single test in isolation. And I think the data from the SHORE registry is, for us, something that we look at to tell us that we're on the right track, where we had, lower biopsies significantly than the rest of the country, but we didn't have higher rates of rejection. So while there isn't randomized controlled data, there are positive signs that what you're doing is at least not causing harm while you're trying to minimize risk. And I think as a trainee at Baylor, a lot of my formative memories came from pathology conference with the great Dr. Bill Roberts. And one of the things he emphasized was that rejection occurs in the epicardial fat and works its way in. And so I always looked at biopsies with a bit of skepticism, and that we're just kind of feeling different parts of the elephant and describing it in different ways. So conceptually, it makes sense, but of course, we need the proper context to use these studies long term. And speaking of long term, why don't we turn to the more end-stage complications, perhaps, that some of our heart failure patients can have, and talk about general prognosis for patients after they've made it through the first year. So we have Mr. Cycla. He's a 65-year-old male who had a heart transplant 20 years ago for non-ischemic cardiomyopathy, who now, unfortunately, has progressive graft dysfunction over the last several years. He was found to have CAV2 on his left heart cath. He now presents to the ED with complete heart block with a ventricular escape rhythm. He's taken to the cath lab where he receives a temporary pacing wire and is found to have progressive CAV on a repeat left heart cath. One of the most significant long-term complications is cardiac allograft vasculopathy, or CAV. Dr. Farr, can you walk us through what we know about the pathophysiology of CAV and how we monitor for it and what we could do to manage it?
Yeah, sure. Boy. Okay. So, first of all, our ISHLT grading system of coronary artery vasculopathy, or CAV, comes from a very small database of angiograms from like the early 2000s. And that has not been revisited. This is another topic Shelly and I have talked about, that we need to do a full reassessment in the contemporary era of what does the vasculopathy look like. Our patients, as you've already mentioned, are going into transplant, 30 and 40% rates of diabetes, hypertension, CKD3, and they're different. They're different than the patients that were being transplanted 25 years ago. So that's the first thing. But what is CAV? It's a combination of both risk factor coronary artery disease, or the risk factors that I just mentioned, but really an immunologic phenomenon of really a vasculitis and progressive obliteration of the coronary trees, starting really with the small branch vessels and then moving its way to epicardial vessels. The grading system is really about the epicardium, but what we know is that probably it's the microvascular circulation that is of greatest impairment. A quick anecdote. When I was at Columbia, one of the T32 training fellows said, hey, can we try to think about moving to PET with coronary flow reserve, compare that to our angiography with IVUS, and do this. This was Kevin Clerkin back in 2014 or 16 or something. And at the time, it was okay to pair these tests. And we did this. And he ultimately was able to write this cohort and published it in JACC to demonstrate that PET with coronary flow reserve really was much more prognostic than standard angiography. And it was much more prognostic based on the microvascular dysfunction and not the epicardial. Like, you could have epicardial disease and stents with sort of more classic coronary disease, but it was the microvascular circulation that was impaired. This has gone on to been I shouldn't say repeated, but in parallel, work from Toronto, work from Michigan. And so thinking about microvascular circulation. So how do you manage CAV? What you manage with risk factor modification, anti-inflammatory therapies, even things like photopheresis, anything that can modulate the immune system. This is very difficult. It is very, very difficult because it portends a severe prognosis for patients. We're sure about that.
Yeah, I think, when I'm telling patients about this, it's typically called, quote unquote, the chronic rejection. And I tell them, think about your blood is continually touching this foreign blood vessel 24/7, nonstop. And that's, an immunologic reaction. The challenge is, as mentioned, our grading scale is so old, and it's by looking at an angiogram, which, as Jane mentioned, is the terminal phase of vasculopathy. Once you have visible stenotic lesions, you're not preventing anything. You're now in a reactionary mode, and you're stenting when physiologically it needs, although there's not been any data that says that that provides longevity. It's difficult to screen them because they're asymptomatic, because they're denervated. So you've got to have some screening method. And that's from, waiting for graft dysfunction on echo to sophisticated things like stress PETs, and everything in between. Some do stress echoes, dobutamine echoes, stress volumes. They do some series of regularity to angiograms. And only a small percentage of programs go beyond that angiogram and do something like OCT or IVUS, which theoretically you're getting to it before it causes obstructive lesions and could potentially intervene. We harp on risk factor modification from the beginning, as Jane mentioned, and then there's different drugs that have been shown in small single center or small cohorts to potentially slow down. So for our program, we do IVUS with our angiograms, and we do a baseline around 6 to 8 weeks so that we know, what did this heart really come from? Because let's face it, most donor casts are 20 cc's spritzed in, hoping you filled the artery, and somebody in the middle of the night begrudgingly, giving you a quick report. And so we always do a baseline again, if their renal function allows, to see what they came with. Because our feeling is, if you don't do that, then you do it at 1 year. Is it vasculopathy, or was it, stuff that was already there to begin with? Because you approach the patient differently. That's a risk factor modification problem versus an immunologic problem potentially, but it's not reimbursed. And so therefore a lot of programs won't do it from that fiscal concern. Some will do OCT. Others they'll do it annually. They'll do it every other year. They'll alternate with stress thalliums. And there's no standard out there of how to survey the patient for CAB, and no standard of when should you start an anti-inflammatory or an anti-proliferative, the mTOR family of drugs, and which ones and how much. And that's another area of complete lack of consistency.
So when I'm counseling my patients prior to transplant, I always try to make it really clear that we're really trading a disease state for a different one. And there can be some extra cardiac complications of transplant long term. Can we just briefly discuss what those complications look like? And also, I would love to hear how you talk to your patients about that.
Okay, so it's completely true. You're trading one disease for another. I also try to be a little bit more sort of hopeful, because I do think that one way in which they're trading is that people actually will feel really good after transplant. And I think they don't really realize how sick they are, and until they get a new heart and they look completely different, they act completely different, and they truly have such a wonderful life that feels like it's worth living. So I think that's the first thing. But it comes with issues and problems, and we already discussed malignancy is devastating and common, and can start with skin cancers, and it can end up to be other things. I think what's really, really important is, if you want to try to get a patient to live 20, 25, 30 years, what's going to happen over those 30 years? And Shelley's been in a program for a long time, and I've been in 2 different programs. And one of the program that I was in previously was one of the earliest programs. So I knew patients who were alive at 30 years, 25, 20, 15, so you've got a full spectrum of what it all looks like. It's really important to tell patients, whatever drugs I'm giving you, whatever I'm telling you today, in 5 years, I'm going to tell you something different. And 5 years later, and at 10 years, you're going to hear something different. And at 20 years, you may have a different doctor, and they're going to be telling you a whole different thing. You want to keep patients in this way of saying, you need to move with the future. Because I think something happens with our transplant patients where they get so nervous that they've been told that they must be on these 3 drugs and those 3 things. And it has to be exactly this way. Someone told them in 1997 that it had to be this way. And then you have to tell them, hey, by the way, turns out this drug may increase your risk for malignancy, and this dose may increase your risk for malignancy. And sometimes it's the patients who say, I'm not changing anything. Don't fix what's not broken. I'll say, it's going to be broken. So I think that's more important. So as we nuance and we learn from each other and research is done, it's really, really important for the patient to know that their survival depends on their flexibility, and allowing us to implement new data and new science.
I think that's great. I also use the terminology, this is not a cure, but an exchange or a treatment with a new long list of medicines, with a new potential list of issues. But the reason we're doing it is to give them a longer, better quality of life. And that's what we hope for. And we can talk about statistics, and ultimately that's for the population and not for an individual. And we're just going to say you're going to be the individual who goes the long run. We know the stats out there for heart transplant haven't changed much in decades. With if you survive your first year, your mean survival after that is 12.9 years. That really hasn't budged in at least 2 decades. And that's because we do struggle with trying to figure out ways to reduce our immunosuppression so we can reduce our side effects and those chronic complications. And we don't have the trials like we've talked about. There's a lot of things that have made it slow, but then there'll be some radical new thing that comes through, and we want our patients to be open to it. I think it's very funny. I when I talk to patients, here we are, we're pounding on them. Have your caretaker and have your med list and have those meds memorized and don't miss a dose or you'll die. Or we pound all this fear into them. And then at 1 year we say, okay, go be free. We'll see you in 3 or 6 months. Imagine the fear that creates. And so I always tell the patients that it's, to me, a fresh transplant patient is like raising a child. The first 3 months is working them up towards getting them to kindergarten. You're not quite attached to them 24/7. And then the second 6 months is going through grades 1 through 12. And at grade 12, we're like, okay, you're a grown up, you're going off to college, but you'll still come home for holidays and you can still call if you're in trouble, but be independent, but don't make stupid choices. And that's sort of what that second year is like, is their college. And then ultimately you hope that they become a productive adult. I'm still hoping all that for my kids. And I use that phrase with them and they get it. They like it, they laugh, but they can identify with it because most of them have been parents or no kids or whatever. And so that's how I approach going from this hyper vigilant world that they live in that first year to the growing independence and really living their life with, a few modifications, but who doesn't?
I love that. Thank you for sharing. I think the language we use with our patients is so important because it really sets a mindset for them, often very long term. And so I appreciate you guys sharing yours. Let's wrap up with a topic that I think many patients are understandably concerned about. And I think that many of us in the transplant community are kind of thinking about and taking part in. And I, as a transplant fellow, have thought a lot about kind of the ethics of it, just prognosis and also retransplantation. So we have a 23-year-old female. She had a heart transplant at 4 weeks old for cardiac fibroma. And over the last 2 to 3 years, she was found to have progressive CAV despite sirolimus, aspirin, and statin. Her graft function is now at an EF of 15%, and she has a CPET that showed a VO2 max of 10. Shelley and Jane, what's the general prognosis, which you kind of mentioned, for heart transplant patients in terms of long-term survival? But also, how do you, I guess, institutionally and personally approach retransplantation?
I'll start on this one. The first is it's considered a rare gift for a precious few. The reality is that when you look at the overall statistics of retransplant, they're not nearly as good as the first transplant. But we have learned that if you divide that up to a retransplant in the first year, that's really where the bad outcome is. And usually, if somebody's losing their graft in the first year, it's immunologic. And you're not going to fix that by giving another new heart tube. Whereas somebody who's gotten their 12.9 years out of it and taken good care of their body and been lucky to, not have kidney failure or other comorbidities that knock them out of the running, they actually can do quite well with a retransplant. So we know that a younger patient is not going to have, statistically, won't have that 12.9 compared to a 55-year-old white man. That's sort of the immunologic sweet spot. And so we know that that's important for, they're going to be thinking about, I'm going to be hitting my 40s or, 30s and be looking at another transplant. And the reality is most end up having comorbidities that make them not a candidate. And that's tough because they're mentally going, wait a minute, I'm going to have to go through all this again in my 30s and, gosh, if they're young women and still want to consider reproduction, that's another challenge to the immunologic state. And it's really hard. And gives you a sense of what oncologists are dealing with all the time when they're talking to young people with malignancies that, yeah, you can live mean is 9 or 10 years from this malignancy. They'll be like, but wait a minute, as they do the math. So, I guess the easiest way to say very few are going to be candidates, but if they're late, farther out, and it's not immunologic and they're not more sensitized than ever, those do better.
Yeah, it's a really, really painful and tough question. I think for both of us, we run adult heart transplant programs, but we both take in young adults who've graduated from their pediatric transplant program, and there's hopes and dreams and plans for the future, as all young adults have. And we tend to be the people that have to talk with patients about their survival limitations. I'm a huge proponent of retransplant. As much as that sounds controversial, I really love to see trying to give young adults a second opportunity, and in rare circumstances, a third. I do think that because there's such organ scarcity in the pediatric community, which is a good thing, such great public health measures with seatbelts and helmets, that there are very few pediatric donors, that a lot of the pediatric patients need to have imperfectly matched hearts against HLA, and then we'll just stay with against HLA for the toddlers and the young adults. So they get into problems with coronary artery vasculopathy and rejection and antibodies. And by the time you meet them at the age of 18 or 21 or 22, they're already in some trouble. And it makes their retransplants challenging. But they grow up and you've got a partner. And it's nice to try to get folks through to a second heart. And that's just one of the things that's just more of an emotional thing. There are so many hearts that we turn down in the United States, hearts that Europe would be so grateful to have. And because we are worried about program metrics and who's got the best program and all this stuff, these are good hearts that can take people many, many years. And if we can get away from that concept, we would have less of an organ scarcity problem, and we could take more chances on people. And in this particular conversation, more chances on younger people.
Yeah, agree.
I have a follow-up question. And you guys are the last transplant episode, so we're going to give a little taste of what's to come for the series. There's so much conversation about, now that we have INTERMAX data that demonstrates that there's good 5-year outcomes, particularly in younger patients with HeartMate 3, I would love to ask what your thoughts and feelings are about doing an LVAD in a young patient in an attempt to, as we talked about, really prolong their life and delay those transplant toxicities that we've talked about. I'm just curious.
All right. I think objectively, it makes sense. When you look at statistics, it makes sense. And I am supportive of the discussion. I think the challenge is those statistics don't apply to an individual, and we don't have good discussion tools to utilize with our patients to compare and contrast those risks. And let's face it, when we talk to patients, no matter what our belief is, there is this tendency that the LVAD is the booby prize if you didn't qualify for a transplant. And I think until we figure out a way to be able to put it clear, the pros and cons of each objectively, most patients are going to go for the transplant, because who wants, a thing hanging out of your belly and carrying around batteries and stuff. But the science is showing that it is reasonable. I just think that we struggle in that at the patient level. I'll leave it there.
I think the same. I think that there's a couple of things. That INTERMAX younger cohort data, there is one statistic that's really important. That is, at 5 years, 40% of the patients have a driveline infection. And driveline infections are painful. They're debilitating. They're expensive. They require hospitalizations. They require surgeries. They can increase the risk for sensitization. They can increase the risk for primary graft dysfunction and inflammatory, higher risk transplant if you're transplanting from a driveline infection. So they're not benign at all. I think everybody, tries to talk to young patients and say, get the VAD first, your heart could recover. Or even if you can know in your heart that the heart isn't going to recover, that they have time from transplant. I think when patients are being faced with stage D heart failure and they know they have a very short survival, honestly, 25-year-olds are not thinking about what life is going to look like when they're 60. They're just not. I have some 25-year-olds at home. They don't thinking about what their life is going to look like 30 years from now. That's just not the mindset. And we cannot force patients to say, this is the only therapy that's available for you. I think when people are so sick, they imagine a life with a normal heart. That's the life that they're imagining. And so even though as physicians and nurses and nurse practitioners and so forth, try to sort of provide all that data, I don't think it resonates. And I don't think it's our fault. I just don't. I just don't think that we're understanding what patients want. They want to know what the next 10 years of their life is. They're not thinking 30.
Thank you. That was great. I really appreciate both of your insights on that.
Well, that was a fantastic discussion, even though we really only scratched the surface of many, many topics. So for those of you listening, if you want to learn more, consider a career in heart failure and transplantation. And I'd like to thank our wonderful guests, Dr. Shelley Hall and Dr. MaryJane Farr, for being with us, and hope you guys enjoy the episode. Thank you.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Bhavya Shah. I'm an intern in the CardioNerds Academy House, Eindhoven, and a fourth-year medical student at Rowan Virtue School of Osteopathic Medicine. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.